On behalf of the American Heart Association, I would like to welcome you to this session, Bridging the Gap, Overcoming Barriers to Advanced Heart Failure Care in Rural Areas. Throughout this session, you will have the opportunity to submit text questions for your speaker using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end of the presentation as time allows. To access live closed captions, please click on the closed caption button found on your screen. All sessions will be recorded and available in the coming weeks. It is my pleasure to welcome our speaker for this session, Dr. Dmitry Yaranov. Dr. Yaranov is an advanced heart failure and transplant cardiologist at Baptist Memorial Hospital in Memphis. He is a medical director for advanced heart failure, heart transplant, and mechanical circulatory support. As a reminder, your full speaker bios can be found in the event lobby. Dr. Yaranov, the floor is yours.
Thank you. Appreciate your invitation and kind introduction. And as I was stating, I'm Dmitry Yaranov. I'm a transplant cardiologist from coming to you live from Memphis, Tennessee. It's about a 6-hour flight and 2 time zones away from Dr. Tran from Southern California. So as we're all very familiar with United States and how regional the care is, I'm going to give you a little bit different perspective on how to mobilize rural communities. So we titled this talk as Bridging the Gap, Overcoming Barriers to Advanced Heart Failure Care in Rural Areas. In the main point of this talk, to give you a case example or a case story about what we call a BMH Memphis model or multi-state outreach program with goal to mobilize rural community to provide access to patients with advanced heart failure. Right. As you already heard, heart failure is truly a serious disease with reduced survival. Dr. Tran gave you data from 2019, and he gave you the projections in terms of the increase in the incidence of heart failure in upcoming decade. Actually, to be fair, we are on track, or even so a little bit ahead of the schedule, because in 2024, we published statistics from Centers for Disease Control and Prevention, a National Center for Health Statistics, and we found out that in 2024, there are 6.7 million adults in the United States with heart failure. Remind you, the projection was to have 6.8 by 2025, and we almost had the same in 2024. And then to complete this by 2030, we will have about 8 million adults out there with heart failure. Heart failure is a deadly disease. Every time I see patients with heart failure, statistics, the crude statistics that we use to describe the mortality is around 50% survival within the 5 years of the diagnosis. What we also know is that about 10% of the patients who are diagnosed with heart failure will actually be classified as advanced heart failure. And again, you just had a great review what is considered advanced heart failure. But there's, over 600,000 patients with advanced heart failure out there now. And certainly about very close to 400,000 patients every year will die with a diagnosis of heart failure in the United States. Hopefully, we all agree how serious the disease is and the rise of incidence. I'll share a different set of statistics of which we didn't talk about today yet, and this is the access to advanced heart failure therapies. So unfortunately, most of heart failure patients who would otherwise qualify or benefit from advanced heart failure therapy do not get those. And I pulled data here from 2 different sources. One is the company data with a left ventricular assist device implants for the United States of America. And a second data set is the heart transplant statistics from UNOS database. And if our estimates are correct, then there's over 600,000 patients that do have advanced heart failure therapy. And the crude estimate of this would be that 10% out of those patients will be candidates for appropriate surgical therapies, namely left ventricular assist device or a heart transplant. That actually the majority of the patients in this country are not getting those therapies, about 90%. And only a little bit north of 10%, 12% will receive LVAD or a heart transplant. So certainly those are very sobering numbers. That is the reason why I'm here to tell you what should be done about it or what can be done about it. As we mentioned in previous slides, there's certainly a lot of different breakthroughs that happen in the field of heart failure in the last decade. Starting with guideline-directed medical therapy, in addition of drugs like Entresto, drugs like SGLT2 inhibitors and others. Also, addition of different devices, whether it's a monitoring and therapeutic devices. Unfortunately, by the recent data, we've seen a spike or consistent increase in heart failure-related death from 2009 to 2014, and continuous increase in heart failure hospitalizations from 13 to 17 in the same data set. What's also very interesting is that there is a clear-cut racial and ethnic disparities in death that are resulted from heart failure. And here I put just a few descriptive statistics and from the data set that you have citation for, is that you can see this is age-adjusted mortality rates for patients with heart failure, with 92 over 100,000 out of 100,000 for non-Hispanic Black patients, 87 of 100,000 for non-Hispanic white patients, and 53 out of 100,000 for Hispanic patients. So you can see the disparities and the differences in the racial and ethnic death in patients with heart failure, which certainly calls for a few future studies and research in this field, but more so change in the health policy to address the health inequity in our particular field that we're talking about today. So another interesting series of publications that are also very recent within the last year is looking at the differences in patient outcomes and access to care in rural versus urban communities. So this is a data span that going for almost a little bit over 2 decades, from 1999 to 2021. In the span of these 2 decades, what we were able to see is that rural patients, when compared to urban patients, have a higher rates of mortality. And in the same paper, what we have seen is that those patients, those differences or gap in this mortality is most likely related due to access to care. Because also what we know and highlighted in this particular work is that when patients do have access to advanced heart failure centers or advanced therapy centers, they usually end up with lower mortality rates. So hopefully, I convinced you that there's a problem out there. And I'm going to start telling you the story based on this single center experience. So let me introduce you to the center, and it's called Baptist Memorial Hospital. So Baptist Memorial Hospital is located in Memphis, Tennessee. It's actually a fairly large 700-bed facility that is a flagship hospital for a 22 hospital system. And this hospital system actually spans across a very rural area of Western Tennessee, with 9 hospitals in this area, 11 hospitals in northern Mississippi, and 2 hospitals in northeast Arkansas. This hospital does have access to advanced heart failure therapies, namely surgical therapies that I'll bring up to the front is left ventricular assist device implantation, heart transplantation. Certainly, there are other areas of expertise within the system where the same type of patient population get in their care. So this is the geography that I just mentioned to you. And if you look at the map on the right to give you a perspective in terms of the distances, the zoomed area is actually Memphis. It borders and where the 3 states do touch each other. And you to get to closest advanced heart failure center north, you'll have to drive for about 3.5 hours. If you were to go east, you'll have to drive for another 3.5 hours, south another 3 hours, and west for another 3 hours. So it's a large geography for a very rural patient population. So what all the dots you're looking at are boots on the ground outreach clinics that were established in the last 6 years. Well, I will give you examples and highlight a few of them just to give you an idea of how they were established after I talk to you about a couple more unique aspects of this area to hopefully you can either find the similarities or differences with the area where you practice advanced heart failure or practice general cardiology. So let's start with payer mix. Certainly this patient population has a lot of patients who have a state-sponsored Medicaid programs for both patients who are receiving a heart transplant and receiving left ventricular assist device. Certainly a lot of implications that come with it, with both reimbursement of the payers and certainly the ability of those patients to travel those distances to get to where they will receive their end organ intervention. High mix of patients with Medicare Advantage plans and a very low compared to other areas, Medicare, true Medicare or traditional Medicare insurances. Very few, but about 5% of each groups patients that receive care at VA centers in the same tri-state area. So to give you an idea of what this metro area looks like, this again, not just Memphis, but the metro area, some sobering statistics and numbers. On the left, you can see the highest level of education among people that are age 25 and older in this population is compared to state of Tennessee in general. You can see that Memphis Metro will have predominantly a majority of the patient in this area will have degree less than high school, and this is from Census Bureau, which you can look up for any region you'd like to. And the main discovery for me was the understanding the household income distribution. And again, this is in comparison to the whole state of Tennessee. And you can see how they compare, but majority of the patients in our metro area will have income less than 35,000. With about 50% of about 15% of patients, 18% of patients have an income less than 15,000. So to drive deeper and again to reinforce the slide that I showed you several slides prior, looking at the differences in the ethno-racial composition of the household income and the gap that we see here in this tri-state area is the striking difference between the incomes on the left with a largely disproportionate between Blacks versus whites versus Hispanics. And you can see on the right, this is an independent household income distribution of the given ethno-racial group, which is normalized to the sum of each interval is 100. So that gets you an idea what type of patient population we're dealing with. And this also gives us an idea what our recipients of our advanced heart failure therapies are going to look like. So just to give you an example, I just abstracted this from the most recent UNIS report, which you also can pull out for any center or any particular region, any particular hospital, any particular state. And this is looking just at the recipients of a heart transplant at TNMB, where TNMB is a UNIS code for Baptist Memorial Hospital. You can see that majority of the patients that receive heart transplant are actually African American compared to 61% of African Americans at TNMB versus 26% of African Americans in the United States in general. So you can split it by gender. You can see pretty much the same type of relationship between the groups. And this is a VAD. Same numbers again we're seeing in this group, this left ventricular assist device for TNMB, and you can see that 60% of the patient that received end-stage surgical therapies will be African American in this geography. So how do we do this? And how did we come up with the idea that I'm about to present to you? Well, first of all, I wanted to talk to you about what traditionally been done. And what traditionally been done is what we call a shared care model. Shared care model, some of you will be very familiar with. Interestingly enough, as we graduate newer fellow generations, most of the fellows won't remember this typical shared care model where there will be an implanting LVAD center, implanting or transplanting center. In those patients with left ventricular assist device will go back to the community where smaller community centers who do not have access will develop protocols, will obtain the equipment, and will take care of those patients in the local communities by themselves, with certainly some supervision and some shared responsibilities with the main center. So most of you or most of my colleagues in the field can certainly agree that traditional shared care models failed in a lot of places. It certainly failed for us back in time. And that's why we went out to understand what other models can we create to be different from this model where, kind of one size fit all the outlying facilities. So the common reasons that we identified at that point that truly failed the traditional model were as follows: slow volume. A lot of those centers will have very few patients implanted a year. So truly not enough patients in those small practices to maintain the expertise and continue to maintain the expertise. Certainly, heart failure nowadays, especially, is a complex process and truly time consuming, especially for those colleagues who are in busy private practices and have to see volumes of patients. That's where the lack of interest most of the time comes from. Misaligned interests, and I'm not just talking about the cardiologist, general cardiologist versus heart failure, also including other subspecialties and primary care physicians, hospital systems, hospital administrators, who always pursue different goals. And those goals sometimes, or most of the times, are actually misaligned in those systems. You get a very sick LVAD patient that goes to the community that starts being readmitted to a hospital, and this certainly carries a big burden to those communities. And a certain fear of bad outcome, because all the providers are, in understanding those patients have very high risk, they carry high morbidity and mortality burden, and certainly, without a true backup of advanced heart failure center, those type of ventures can be high risk and a lot of times can demotivate the whole team. So keeping that in mind, we continued our venture, and as you've seen in Dr. Tran's presentation, all of us are big believers of community outreach. Community outreach most of the time is a driver for volume and two, access for the patients. Community outreach always starts with engagement before we expect any type of referrals. And I'm not going to belabor this, but you've heard a lot about different strategy of engaging this community, especially initial engagement. But we also are big believers that the team introduction, not just service introduction, is the key of successful introduction of these outreach model. But what I mean is that our nurses, our nurse practitioners, and all of our MDs are a big part of our outreach model. They all believers in it, and they are present in the community. Certainly, we don't just wait for those patients to come to us, and we go to where those patients are. And majority of our patients in those communities taken care of by general cardiology or primary care doctors. So building relationships is the key before we build any type of workflows. And the biggest part of building those relationships is understanding that all of those smaller practices usually have their own goals, and understanding of their goals is very important. And that's where our approach has changed drastically with regards to not one size fits all, which is usually implied in a traditional shared care model. Education and engagement most of the time builds trust. As you know, trust is not given, you have to build it. And we're big believers in that as well. We believe that identifying those regional and local champions is critical, whether it's nurses, nurse practitioners, PAs, MDs, primary care doctors, hospitalists is important. Elevating their expertise is very important. And local multi-level education is a paramount of success of any outreach strategy. Followed by patient-facing education to making sure that we get to those patients even if we experience certain barriers. So what's different this time? What is this model of not one size fits all? It's truly employing that hub and spoke models, which are already very well established in areas like shock, or other subspecialties, and cardiologists and other subspecialties for internal medicine. The second level to it is certainly centralized expertise is critically important, but access should be decentralized. MD and APP-led local clinics act like a spoke models, coordinators, whether it's a transplant vet coordinators, heart failure coordinators, are usually put as a hub. And this allows for a true local follow-up, triage, identification, and limits trips to the hub, which is major barrier for our patients who are not able to travel far enough to get to advanced heart failure center. And certainly strategically placed advanced heart failure clinics to making sure that this multi-level expertise stays in the small communities and improves the access. So certainly one thing that we spoke a lot in the previous presentation, and I'll just reinforce this one more time. One of the things that COVID truly brought to us out of the positives was the telehealth and remote monitoring that accelerated at that time and helped our program succeed within those rural communities. So telehealth not just to apply to stage B and C patients, but certainly here I'm talking more about telehealth applied to and remote monitoring for stage D patients. Those patients where they're being considered for advanced heart failure therapy or patients already selected for advanced heart failure therapies that do undergo surgical interventions that return back to those communities and not burdening the local providers, but rather us finding resources and finding options how to continue to follow those patients and make sure that this burden of travel to mothership is not a barrier for them anymore. I just put a very few examples here, and we can talk a lot more about it, and it's a whole conversation in its own. But surely this is mainly focused on patient-centered care. And a lot of times this depends on patient needs, whether it's a patient with a driveline infection who is doing a video calls or sending pictures to coordinators, whether it's just a local expertise of echo lab for those patients who need their 3-month echo after discharge, or they're truly having struggled transitioning out of the hospital to local communities, employing services like a home-based NP services, home health services that are available in our community to those patients, usually to less sick patients, but certainly making sure that those services are also available to advanced heart failure services. And what the system created is this created this what I call a grid for outreach strategy or growth strategy, if you will, to make sure that those patients are plugged into the system. This is somewhat very specific to our center. Again, this is just a somewhat a roadmap, but I'd like to think about this in three different headings or three different pods. The first one is InReach. There's a lot of us who are talking about InReach, and every time we say that if we could only figure out InReach, we'll get busier right away, and there'll be no need to travel. But that is, truly defeats the purpose because we are talking about access in rural patient populations. Leading the service lines, what's interesting in my hospital back in the time when we started this initiative, out of 22 hospitals in the system, very few knew about the advanced therapies that are available at the mothership. So educating your own system is critically important. Boots on the ground clinics, where clinics are strategically placed in different geographies, whether it's Southern California or it's Mid-South. It's critically important. Certainly we are also underproducing advanced heart failure cardiologists. Telehealth is critically important, not to just follow those patients, but also reach those rural communities where telehealth clinics can be deployed, whether it's in a primary care offices, whether it's in the general cardiology offices, or any other settings. That's number one. The second part of it, or part of this discussion, is true outreach, what we call when we are living our native system. So I'd like to think about those also in two: conventional outreach and non-conventional outreach. So conventional outreach, again, heard a lot. I'm not going to talk about it for a minute, but I will rather focus on non-conventional outreach for a few seconds here. So whatever we do, however we're trying to reach our patients, there are still politics involved in cardiology, and there will be centers, there will be practices that would not want to communicate with us. We'd like to on a clinical level. But certainly there are some other needs that those practices may have. We need to really understand the goals for those practices and what we can be helping with. Whether it's a fellow education, some of those practices will be trained the fellows without access to advanced heart failure therapies. Whether those practices are in need on any particular part of the access to advanced heart failure, namely one of the practice will need shock system and help with that and offload those patients, and the practice may be thinking about DT LVAD program in the future where you'd like to help them with, and finally get into those practices. So no, we don't take no for an answer. That's why conventional outreach is a lot of times a strategy where we deploying those practices outside of the true collaboration that we have in these communities. And the third one is disease and program awareness. And this is truly patient-centric in the sense that we want to go to where the patients are, both physically and digitally. Because it's truly important for our patients to be aware of the therapies that are available in the region. If your patient does not know that this therapy exists, they likely not going to be able to advocate for themselves. We certainly got a lot of referrals for very unfortunate patients that, after being put on hospice or get on home palliative inotropes, they finally learn about the other options and they get to us. Hopefully, after we truly deploy this in-reach and outreach strategies and forget about the politics and healthcare, we need less and less of this. But unfortunately, we, to break this paradigm of lack of options for those truly rural, underserved areas, we need to go to our patients directly and make sure they're educated on the disease state. So I'll give you a couple examples just to highlight certain things, not just to bore you with this, but different practices in our region needed different things. One of the highlights of ours was our initial engagement with a very sophisticated practice without access to advanced heart failure therapy in Northeast Arkansas. As you know, heart failure, like we mentioned in the previous presentation, the differences between stage C and stage D is very murky. And understanding the transition of patient from this stage C all the way to stage D and timely transition of it is somewhat simple in patients within the advanced heart failure world because we utilize this functionality called cardiopulmonary exercise testing. Unfortunately, cardiopulmonary exercise testing is not something that is uniformly available within all the cardiovascular communities. And access to this therapy is not just helping the patients, but also helping the local providers a lot of times understand the difference between stage C and stage D. This practice was one of our first practices where we, thankful to our foundational funds, were able to bring the cardiopulmonary exercise testing expertise for two reasons. Number one is to be able to stage the patients locally to make sure that we eliminate this extra step in the workout that patient have to do in the local community. But also to be able to explain to local cardiologists that in their practice time did not have access to this test, that those patients who are walking into your office seemingly doing well are truly not doing well. And with this type of testing available in those communities, you can predict the events a lot better and eventually transition, or hopefully transition, those patients to an advanced heart failure world a lot faster. So Let's see if I can advance. Okay, you controlling the slides because I cannot advance anymore for some reason. Thank you. Um, there's another practice, and again, this practice in the same exact region, and this practice had great aspirations of having a DT VAT center. And actually, they've opened a DT VAT center in the last 2 years, which is a great success, not just for the center, not for just us, but for all the patients in this community. Because ultimately, you want to provide a lot of the services locally, and to date, we know that there are patients, even though I am present in those communities, most of them will not be able to drive that far to even get the index implant. And this is the first story of long-term outreach, how this transpires into a DT VAT center. And hopefully, maybe at some point, next steps in that community. Another great success story, this center that does not aspire to become a VAD or transplant center, but certainly a center who wants to be a very high profile shock center. The center is now ramped up their capabilities of temporary mechanical support and through the collaboration, our support to the center. They're able to truly create this old school shared care model where the expertise is up to speed. They're very comfortable with very sick patients now taken upon all the a few steps over just a regular local outreach center. Next one, another example is a very far away center, 3 hours away. This is again 6 years ago for us. This would be unimaginable to implant a NALVAT into a patient that lives over 3 hours away. For our geography now, it's totally possible because we were able to get into the center that does not have capabilities of taking care of that patient, but are able to fully buy into this hub and spot model and continue to advance their expertise in advanced heart failure centers. So the bottom line of this, I give you 4 different examples, is that the goals for all of those centers were completely different. And when we come to those centers, we'd like to have them their wish list filled out to make sure that we understand what expertise is required from us, making sure that we elevate their expertise and we get them to where they want to be, ultimately get an advanced heart failure centers or care to those patients in those truly rural communities of Arkansas, Mississippi, and Tennessee. Again, we talked about it briefly. I'd like to say that the process should be very seamless, both for referral and evaluation. We are certainly, a product of our training all the time, and unfortunately, a lot of us who are practicing advanced heart failure, actually general cardiology right now, were trained at the times of previous generations of LVADs, lack of access to remote pressure monitoring, things like this. So nowadays, certainly the world of this has changed, and our ability to streamline processes like evaluation of those patients in the community is very important. So any process starts with a seamless referral, whether you working on the telephone line, where you're working on the any type of line, whether it's the medical director phone or just cardiologist phone. The clear cut here, or the clear message here, it has to be super easy. 901-226 LVAD, you can call that number and get the referral, and you'll get a call back within 24 hours. If it's an urgent call, you click 1 and you will get answer right away. So however, whatever works for your community to make sure that you can access to advanced heart failure therapies immediately, that works in your favor. Second, again, I'm highlighting certain things that I feel like is very important. Transplant Program Liaison or Outreach Coordinator. This position is somewhat newer, not so much the liaison, which is a usual physician liaison who can go to the community and make sure that we present the program, but outreach coordinator. This is a highly trained nurse who's specialized in advanced heart failure, who's coordinating the care of those patients in the community, who's coordinating the referral process, the evaluation process in the community, and ultimately transition of those patients from this true stage C all the way to stage D, and making sure that patient making their way to surgical intervention down the line. And the dedicated advanced heart failure coordinators and pre-implant coordinators, both for VAD and transplant, that are heavily involved in outreach strategy, completes that whole paradigm of multi-level education system where nurses pair with nurses, where APPs pair with APPs, and MDs pair with MDs, making sure that no one is intimidated in the process, that nurse does not have to call an MD, or NP does not have to call an MD, to make sure that peer-to-peer communication exists and peer-to-peer communication thrives. Majority of the team members understand that burden on the families and lack of education for those families facing advanced heart failure therapies. That's where we utilize, again, telehealth technologies or educational and testing in the community to make sure that patients either truly qualify for advanced therapies before they reach the implanting center, or those patients are educated in those community to remove the perceived barriers of lack of education, lack of understanding, and so on. And certainly the selection committee. Selection committee is very nimble committee. We'd like not to call it a transplant committee anymore. This, again, advanced heart failure committee, where most of the patients are by default worked out for advanced therapies. And whatever therapy is best for them is decided by the committee, which applies different standards to different type of therapies. Committee can be remote. Committee can be joined by different centers. So sometimes we have referring physicians that are presenting to committee. Sometimes they're just joining the committee to hear their patient presentation. And this is another strategy that we utilize to make sure that there's a peer-to-peer education and understanding what can be done in 2025 for those patients with advanced heart failure. Okay. Again, just a couple highlights here. Advanced heart failure right now is not just access to heart transplant and left ventricular assist device. Toolbox has grown through the years. Starting with different tools for remote GDMT titration, where by APPs or PharmDs, we utilize different virtual platforms that can assist our patients within the community without leaving their community for weekly titrations of the drug with the hope of LVEF improvement or recovery. Certainly elevation of the expertise to understand the etiology of the heart failure and the cardiopulmonary exercise testing or right heart cath that is done in the community. Nowadays, I can say that most of the testing and the most rural communities that we have here in the Mid-South, especially for those patients considered for left ventricular assist device, can be done locally, including the education of it. And then certainly the treatment options has grown, as I mentioned to you, and decision does not always end up with VAD or transplant. There's newer devices, there's newer tools we utilize, whether it's CardioMEMS, CCM, Barostim, multidisciplinary valve teams, and so on, including their research trials. So all of this can be done in the local communities to improve the access for those patients, to limit the travel time before the decision, so that way those patients can truly be triaged on the distance. And the last but not least is engaging a broader community that exists out there that takes care of different patients with advanced heart failure. I'm always impressed where our referrals are coming from. Not all of them are coming from cardiologists. And we usually educate on a different levels within our communities, whether it's education for emergency room doctors, whether it's education for outpatient dialysis center who will receive eventually those patients that leave and most of the time will have trouble accepting or will trouble understanding the pathology and so on. Again, this is just a few examples. It certainly by any means is not limited to this approach. But the one approach I want to bring up to the table, and I want to say that is by far one of the most successful in the peer-to-peer education is, can be called different ways for us. It's called APP Journal Club. And this is not just a, pictures of what you see in this room. It's actually APPs from all the tri-state area. It happens on a quarterly basis. It's APP led, and it's centered around APPs. making sure that we elevate APP community knowledge. Why it's so important, I'll just give you some statistics from the advanced heart failure world. Most of the work that we do is driven by APPs because we constantly underproduce heart failure providers. It's very hard to imagine that at some point in near future we'll have enough advanced heart failure doctors take care of all the advanced heart failure patients. Absolutely not. That's why this venue is very important for us. In the last 4 years, we've been running this, and truly the amount of patients that walk into this door through a referral from a nurse practitioner is just tremendous. So to wrap it up, I'll give you a couple slides here. This is, certainly what's interests cardiologists on the left is the growth. There are certainly increased amount of referrals for advanced heart failure therapies. But what's important more so for our rural community is how this graph on the right has changed significantly. And you can see that nowadays, if I were to show you this graph about 7 years ago, it would be very different. Majority of the patients actually were coming from Memphis proper because of this, perceived barriers in the advanced heart failure therapies that they require you being proximal to an implanting center. And you can see that majority of our patients right now actually do not come from Memphis metro. They actually come from outside of Memphis, split in between three states. And a lot of those patients have to drive or their distance from the implanting center is actually over 150 minutes and so. So truly it's doable. It's doable in a very rural, very underserved, very poor patient populations. It's just a matter of vehicles that you utilize to drive that care. And just to sum it up, we certainly talked about that heart failure remains deadly despite all the advances that we had. And it's certainly if not yet, should be a emergency in the heart and cardiology space. 50% mortality within 5 years and almost 400,000 annual death. Rural populations do face higher mortality, and in most cases, this is due to limited access, whether due to perceived limitation or perceived barriers, or due to true barriers in relationship to payers, access, and so on. Traditional care model, at least within our system, truly usually fails. It failed for us, and mainly because of the interests that were misaligned, mainly because of the implication that one size fits all. That's how the most of the shared care models were built back in time. And truly the model that redefined our system is proactive, multi-state, multi-level outreach approach to that is mainly focused on patient access. Hub and spoke, vet care, telehealth, advanced heart failure care, and a local partnership that bring care closer to home are essential and will drive the closing of the gap that I showed you in the beginning of this conversation. And the result of it is scalable and trusted care delivery that improves access and saves lives in the communities like Mid-South. So right on the 45 minutes, I'll open up for questions.
Yes, thank you, Dr. Yaranov, for that informative presentation. We do have some time for some questions, and so I'll kick it off here with the first question. Do you have any recommendations to get C-suite buy-in to build outreach programs to smaller rural communities?
Absolutely. I certainly didn't focus much on this, but aligning interests, that's where this question goes into. I think one very important point is that unless your interests are aligned with your administration and C-suite, most of this will be absolutely impossible. Outreach itself, as me seeing 30 patients in the rural community, especially when the majority of the testing and majority of the tests stay in that rural community, does not make sense for my system. Understanding of the downstream effect of all of this is clearly important. The downstream effect is not just focused on the transplant and VAT, which are clear under, which are very, very clear makers for any hospital system out there, especially in the current transplant system. But more so is understanding that there is a big, toolbox that we do have that also, creates, and sustains the lights in the hospital, in my office, and so on. So another big part of it is quality of care and patient outcomes, which a lot of time highly ties into a length of stay. Majority of the patients who undergo advanced heart failure therapy, they arrive to an implanting or transplanting center at the right time, will get through the system with a good outcome at the right amount of time. So that's another clearly important point, that education and presence in the community actually yields those patients that are timely approached, as opposed to be a crashing and burning, transfers into advanced heart failure center, where a lot of times you can't divert those patients and divert those transfers. We do see that through the last 6 years employing this model, we have noticed a drastic change in the patients that receive transplant or VED, primarily by their Intermax class. Intermax class, a lot of people who are in this call are very familiar with. In the center that, for us, as a center who used to do primarily Intermax class 1 and 2, very sick patients that are crashing and burning, nowadays we're able to see transition, and we do see a lot of patients with between class 2, class 3, and those patients who get those therapies truly timely. This dictates a quality care that improves patient survival, the likelihood of those patients of surviving and continuing to be in the system are high. And that's where a lot of times C-suite usually listens to you and gets that buy-in for you to afford to be able to do this regional outreach.
Yes, thank you. Kind of to dig into that a little bit further, you talked about strategically placed advanced heart failure clinics. What criteria do you look for in selecting locations?
Yeah, very important point. One is the first and foremost criteria is distance to our patients, and making sure that that does make sense for the patient. We rarely would put two clinics within the same exact region unless there's a strategic and important need. Most of the time, when we come with advanced heart failure therapy, our goals are very different from general cardiology goals. So we do not compete for the same type of revenue, if you will. We do not compete for the same type of RVU. So it's a little bit easier for us to say that we're here not to compete. We're here rather to support you in this community. That's number one. Number two is, again, the goals of the local community. If the goal of the local community is to create a DT LVAD center, we would most likely support this goal and build the center up to make sure that we, both succeed. And there's truly, if those two centers are close by, unless there's insurance, insurance dictates otherwise in this community, then most likely every patient will go to the center that has access to the most of the advanced heart failure therapy. Likely it's no need to put center outreach clinic in a center next to DT VAT center that that defeats the whole purpose. And I think those are two major goals for us, is to make sure that it's geographically making sense for our patients, and two is that it aligns the goal of that community.
Thank you so much. And again, we just want to say thank you to Dr. Yaranov for a wonderful presentation, and we want to thank our audience for your participation. Coming up next at 2:55 p.m. Central, we have our next session, Substance Use in Advanced Heart Failure, Breaking Barriers to Advanced Care. To access, please exit this session and return to the lobby using the menu at the top of your screen. From the lobby, click on the Sessions tab first, then click on the individual session to join. We've also posted a link to join directly in the chat, and thank you very much for attending today's session, and we will see you shortly.
Thank you.